Welcome back to the deep dive. Today, we're cutting through the complexity of heart failure pharmacology, using that foundational chapter summary you shared as our roadmap.
Yeah, it's a dense topic, but we'll break it down.
Our mission is to give you the shortcut to mastery, focusing on the core drug classes and, importantly, the safety practices governing heart failure treatment within Canadian healthcare.
Exactly. Distilling all that therapeutic evolution and the clinical risks into what you really need to know.
So where do we start? Foundational concepts first.
Absolutely. To even discuss how these drugs work, we have to establish the mechanical language of the heart. We often talk about manipulating the cardiac machine using what we call the three dials.
Ah, the tropics. That's the language of heart failure. All right,
Really?
let's make sure everyone has those straight before we dive into the disease.
Okay, good plan. First, we have the inotropic dial. This affects the force or, the energy of muscular contractions. So a positive inotrope increases that force. A negative one decreases it.
Inotropic force. Okay.
Second is the chronotropic dial. This one's strictly about the rate of the heartbeat, faster or slower.
Chronotropic rate. Got it.
And third, the dromotropic dial. This influences the speed of conduction, how fast electrical impulses travel within the heart tissues.
Force, rate, speed, ino, chrono, dromo. You really do need those.
You have to know those three to understand the mechanisms of action, yeah.
Okay, so if those are the dials, what about the condition itself, heart failure? It's basically a systemic mechanical failure, isn't it?
Pretty much. It's a syndrome where the heart just cannot pump sufficient blood, get insufficient cardiac output to meet the body's metabolic needs. And what, as you said, is really about where the symptoms show up.
Right, the left versus right distinction.
Precisely.
Right.
So left-sided heart failure often means fluid backing up into the lungs. That gives you coughing, dyspnea, pulmonary edema. The classic mnemonic is left equals lung.
Left equals lung. Easy to remember.
And right-sided failure. That tends to show up as systemic congestion, fluid retention out in the periphery, so you see pedal edema, maybe jugular venous distension, even ascites sometimes.
Okay. And if heart failure is fundamentally about pumping efficiency, what's the key measure we use, the index for that?
There would definitely be the ejection fraction, or EF. It's basically the proportion of blood the ventricle pushes out with each beat compared to the total amount it held just before contracting. That's the left ventricular end diastolic volume, or LVEDV.
And what's considered normal?
A normal, healthy heart is usually around 65% EF. Pretty efficient.
And knowing that number is critical because the treatment changes dramatically based on it, right?
Absolutely. The Canadian guidelines classify patients into three main groups based on that left ventricular EF, the LVEF. You've got heart failure with preserved ejection fraction, that's HFpEF, at 50% or greater.
Okay, preserved is 50 plus.
Then there's mid-range, or HFmEF, which falls between 41% and 49%.
Mid-range 41 to 49.
And then the category where our drugs often have the biggest impact. Heart failure with reduced ejection fraction, HFrEF, that's defined as 40% or below.
HFrEF, 40% or less. And that's the group where the modern treatment approach really shines.
Exactly. That low EF is what really drives the current treatment paradigm. And we have to stress the old cornerstone drug, digoxin, it's just not first line anymore.
A huge shift.
A massive shift. The focus now isn't just managing symptoms day to day. It's about actively using pharmacotherapy to try and delay or even reverse that harmful left ventricular remodeling and hypertrophy. It's a multi-pillared strategy now.
Okay, let's unpack those pillars then. The new standard of care for HFrEF based on those 2021 Canadian Cardiovascular Society guidelines. First up, the ACE inhibitors. Lisinopril is a common one.
Right. ACE inhibitors are crucial. They work by blocking the enzyme that converts angiotensin I, which is inactive, into angiotensin II, which is a really potent vasoconstrictor.
So by stopping that conversion, you stop the body's sort of overreaction to the heart failing.
Exactly. It prevents that vasoconstriction, and it also prevents aldosterone secretion. Aldosterone normally tells the kidneys to hang on to sodium and water.
Ah, so it's got multiple benefits. Blocking one enzyme gives you vasodilation, less fluid retention. And you mentioned it slows remodeling too.
Yes, that's a key long-term benefit. By reducing the pressure the heart pumps against, afterload, and the volume it has to handle, preload, it lessens the strain, which helps slow down those detrimental changes in the heart muscle itself. It causes diuresis, decreases blood volume returning to the heart, reduces preload, and ultimately just decreases the heart's workload.
Okay, but the big clinical takeaway, the thing everyone knows about ACE inhibitors,
is that cough, that dry, irritating cough. It's thought to be due to bradykinin building up, which normally gets broken down by ACE.
And if a patient just can't tolerate that cough,
then you switch them, usually to the next pillar, or rather a related alternative, the ARBs.
Angiotensin II are receptor blockers. Like valsartan, how do they differ?
They achieve basically the same beneficial end result, vasodilation, reduced systemic vascular resistance or afterload, but they work by directly blocking angiotensin II from binding to its receptors, rather than blocking its production.
So they bypass that bradykinin mechanism.
Exactly. Which means they are significantly less likely to cause that annoying cough. They do share many of the other potential side effects, though, including the really serious risk of fetal harm if used during pregnancy. That's critical.
Okay, so ACEs and ARBs form one major foundation. What's pillar number 2?
Pillar 2 is the beta blockers. But not just any beta blocker. Specifically, 3 has shown clear mortality benefits in HFrEF trials.
Which ones are those again?
Bisoprolol, extended-release metoprolol, and carvedilol.
And their mechanism,
Failure.
it seems a bit counterintuitive, right? Slowing down a failing heart.
It does seem that way initially. But these drugs are fundamentally cardioprotective. Chronic heart failure leads to the sympathetic nervous system being constantly activated, flooding the body with catecholamines like adrenaline. That's actually damaging to the heart muscle over time. Beta blockers shield the heart from that chronic overstimulation.
So they reduce heart rate, delay AV node conduction slightly, reduce contractility a bit. It's about giving the heart a break.
Precisely. And reducing myocardial automaticity, which can help prevent arrhythmias. You mentioned carvedilol. That one's a bit unique, isn't it?
Yeah, it's non-selective, hitting both beta-1 and beta-2 receptors, but it also blocks alpha-1 receptors.
Right, which gives it additional vasodilating effects, helping to reduce afterload. Plus, it seemed to have some antioxidant properties, too.
Okay, so ACE-ARB, beta blocker. What's next? Are we on to the third pillar?
Third pillar, yes. These are the mineralocorticoid receptor antagonists, or MRAs. Drugs like spironolactone or epinephrine.
And where do they fit in? Usually later stage.
Often used in patients who are still symptomatic despite ACE-ARBs and beta blockers, yeah. They block the effects of aldosterone, that hormone we mentioned earlier. This helps reduce sodium and water retention, which is really beneficial for managing the edema that worsens heart failure. Spironolactone is also known as a potassium-sparing diuretic.
Good point. And the newest pillar, the one added in the 2021 guidelines.
Ah, yes. The SGLT2 inhibitors. This was a big development. We're talking about drugs like dapagliflozin and empagliflozin.
Originally diabetes drugs, right? But the key insight is...
The key insight is that their benefit in heart failure extends beyond glucose control. They reduce morbidity and mortality in patients with symptomatic HFrEF, and actually now also in HFpEF, regardless whether the patient have diabetes or not.
Wow. How do they work then, if it's not just about blood sugar?
Well, they inhibit the sodium-glucose cotransporter 2 in the kidney tubules. This stops the reabsorption of glucose and sodium back into the blood. So you get rid of extra sugar, yes, but critically you also get rid of extra sodium and water.
Leading to diuresis and reduced blood volume.
Exactly. It reduces preload, possibly afterload too, and seems to have other direct beneficial effects on the heart and kidneys. It's a real game changer adding this class as a foundational therapy.
So that's the four-pillared approach for chronic HFrEF management. But what happens when things go acutely wrong, when a patient decompensates?
Right. Then we often move beyond the daily oral meds. We start talking about short-term, high-impact intravenous therapies, usually in a critical care setting like the ICU.
And this is where we encounter drugs like the phosphodiesterase inhibitors or PDIs. Milrinone is the main one mentioned.
Correct. Milrinone is often called an inodilator.
Inodilator, I like that. Why?
Because it provides both positive inotropy, increases contractility, and vasodilation. It does this by inhibiting an enzyme called phosphodiesterase type 3, which leads to increased intracellular levels of cyclic AMP.
So stronger pump, wider pipes. Sounds good for acute failure.
It can be very effective short-term. But the evidence is really clear. These are not for long-term use. Studies showed increased mortality with chronic PDI therapy. The main danger in the short term is dysrhythmias.
How common is that?
Primarily ventricular dysrhythmias. The source notes it occurs in about 12% of patients receiving milrinone. Hypotension and hypokalemia are other key risks to watch for.
And there's a crucial IV compatibility warning, too.
Yes, absolutely critical. Furosemide, the diuretic Lasix, must never be injected into the same IV line as milrinone. It will precipitate immediately, forms a solid. Very dangerous.
Good catch. Okay, what else might we see in that acute, unstable setting?
Dobutamine hydrochloride. This is a beta-1 selective vasoactive adrenergic drug. Its main action is positive inotropic. It strongly increases heart muscle contractility to boost cardiac output.
So, similar goal to milrinone, but different mechanism.
Right. Beta-1 stimulation versus PDE inhibition. Dobutamine is specifically for acutely decompensated patients who are hemodynamically unstable. And like milrinone for this purpose, it's given only as a continuous 5e infusion.
Okay, moving away from the critical care infusions now. What about more specialized oral therapies? Ivabradine was mentioned. What's its niche?
Ivabradine is quite interesting. It's an SA node modulator. Its mechanism is very specific. It inhibits what are called F channels, or funny channels, within the sinoatrial node, the heart's natural pacemaker.
And the effect of that is?
It selectively reduces the heart rate. It does this without significantly affecting contractility or conduction velocity in the same way a beta blocker might.
So when would you use it?
It's indicated to reduce the risk of hospitalization in patients who have stable symptomatic chronic heart failure with a reduced LVEF, specifically 35% or less, who are already on their maximum tolerated dose of a beta blocker, but their resting heart rate is still stubbornly high, usually defined as above 77 or 80 beats per minute.
A very specific set of criteria. Side effects.
The main ones are bradycardia, as you'd expect, but also potentially hypertension, atrial fibrillation, and some visual disturbances patients might report seeing bright lights, colored vision, or halos.
And interactions. The source highlighted one.
Yes, it's a substrate for a major metabolic enzyme in the liver, CYP3A4. This means other drugs, or even foods that strongly inhibit or induce CYP3A4 can really mess with ivabradine levels.
Like what?
The classic example is grapefruit juice, a strong inhibitor. It can dramatically increase ivabradine levels, raising the risk of bradycardia and other side effects. So patients need counseling on avoiding those interactions.
Good point. We also need to touch on a specific combination therapy. Hydralazine isosorbide denitrate. Why is this singled out?
This combination, often available as a fixed-dose product, has specific approval and demonstrated efficacy, particularly in individuals identified as Black. Clinical trials showed significant reductions in morbidity and mortality in this specific patient population compared to placebo, acknowledging that there can be differences in drug response, potentially related to underlying pathophysiology or genetics in heart failure among different groups.
Okay, important nuance there. And one more adjunctive therapy you mentioned, omega-3s.
Yeah, omega-3 polyunsaturated fatty acids, or PUFAs. The Canadian guidelines do recommend them as an adjunctive therapy. There's evidence, particularly from studies post-myocardial infarction, suggesting they might reduce mortality. It's seen as a complementary approach.
All right. Now, the granddaddy of them all. The drug that basically was heart failure treatment for, 200 years? Digoxin.
Digoxin, or derived from the foxglove plant Digitalis purpurea. It's got such a long history.
It's like the pharmacological equivalent of, I don't know, using a powerful but slightly unpredictable old musket. It definitely works, but that margin for error is just terrifyingly narrow.
That's a really good analogy, actually. It fits its mechanism and its risks. Digoxin has complex effects. It gives you a positive inotropic effect.
Increasing the force of contraction? How?
By inhibiting the sodium-potassium ATPase pump in the heart muscle cells. This leads to an increase in intracellular sodium, which then indirectly increases intracellular calcium levels. More calcium available means stronger contraction.
Okay, stronger pump. But it does more than that, right?
Yes. It also has negative chronotropic and negative dromotropic effects. It reduces the heart rate and slows down the speed of electrical conduction, mainly through the AV node. It does this partly by increasing vagal tone, stimulating the vagus nerve.
So, slower rate, slower conduction, that allows more time for the ventricles to fill during diastole.
Exactly. So the overall goals are improved stroke volume, maybe a reduction in heart size during diastole because it's not so overloaded, and definitely improvement in symptoms and quality of life for many patients.
And this is the crucial but. Why is the source material in modern practice so clear that it's now only adjunctive therapy, not first line?
Because despite those benefits, study after study has shown no apparent reduction in mortality associated with digoxin use in heart failure. It makes you feel better, it helps control symptoms, especially if they also have atrial fibrillation. But it doesn't seem to make them live longer in the way the four pillars do.
So it's reserved now. For whom?
Typically, it's considered for patients with HFrEF who also have atrial fibrillation that needs rate control, or for patients who remain moderately to severely symptomatic despite being fully optimized on those four foundational pillars, the ACE, ARB, beta blocker, MRA, and SGLT2 inhibitor.
And the really scary part you alluded to, that narrow therapeutic index.
Dangerously narrow, yes. The target therapeutic serum level for heart failure management is actually quite low, usually aimed between 0.5 and 0.9 nanograms per milliliter in GML.
zero point 0.5 to zero point 0.9, that's tiny.
It is, and levels just slightly higher, often considered above 2.0 or definitely above 2.4 ng/ml, frequently lead to toxicity. This razor-thin margin is why meticulous monitoring is absolutely paramount.
And we need to know the classic signs of toxicity. What are the big red flags to teach patients and watch for?
They fall into a few categories. First, GI symptoms are very common early signs.
Yeah.
Anorexia, loss of appetite, nausea, vomiting, sometimes diarrhea.
Okay, GI upset. What else?
Then you have CNS symptoms.
Mm.
Headache, fatigue, confusion, disorientation, especially in older adults.
CNS changes, and the really distinctive ones.
The ocular symptoms. These are classic textbook signs. Patients might report blurred vision or seeing things in weird colors, typically green, yellow, or purple halos or tints around objects, sometimes just generalized halo vision.
Wow, colored vision. That's specific. And cardiac signs, too.
Of course. Bradycardia, a very slow heart rate or various degrees of heart block, can occur as toxicity worsens. Basically, an exaggeration of its therapeutic, negative chronotropic and dromotropic effects.
And certain things make patients much more likely to become toxic, right?
Absolutely. Key predisposing factors. Low potassium levels, hypokalemia, and low magnesium levels, hypomagnesemia, significantly increase the heart's sensitivity to digoxin, making toxicity much more likely even at normal drug levels.
So checking electrolytes is vital.
Critically important. Also, because digoxin is primarily excreted by the kidneys, any decrease in kidney function can cause the drug to build up. Advanced age often goes along with reduced kidney function, increasing the risk further.
And interactions are a minefield, too.
Oh, definitely. There are many, but some major ones include common cardiac drugs like amiodarone, quinidine, and verapamil. These can actually increase digoxin levels by as much as 50%, requiring a dose reduction if they're started.
50% increase. Wow, even diet matters.
Yes. High-fiber foods, particularly bran, can significantly decrease the oral absorption of digoxin if taken at the same time. And some herbal supplements, like ginseng or licorice, might increase the risk of toxicity.
Okay, so if toxicity does happen and it's severe, is there an antidote?
Yes, thankfully there is. For life-threatening toxicity, think severe, symptomatic bradycardia, unresponsive to atropine, dangerous hyperkalemia, certain arrhythmias, or a massive overdose, we use digoxin immune fab. The brand name is often Digifab or Digibind.
How does that work?
It's basically antibody fragments that specifically bind to free digoxin molecules in the bloodstream, inactivating them and allowing them to be cleared by the kidneys.
And a monitoring quirk after giving it?
A very important one. After giving Digifab, the standard blood tests for digoxin levels will be falsely elevated for days, maybe even weeks, because the tests measure both bound and unbound drug. So you have to monitor the patient's clinical signs and symptoms, not the lab value, to gauge effectiveness.
That's a crucial point. Okay, this naturally leads us into the practical application, the nursing process, patient safety. What are the absolute must-dos?
Well, the overarching theme for all these heart failure drugs, but especially for digoxin, is that vigilance is key. The nurse is often that final safety check. It demands a kind of clinical ritual.
So before giving any HF drug, what's on the assessment checklist?
Non-negotiable basics. Monitor blood pressure, check for any edema, peripheral or pulmonary, and assess the heart rate and rhythm. Specifically, take both the apical pulse and the radial pulse, listening or feeling for a full minute.
A full minute. Why is that so important?
To accurately assess the rate and detect any irregularities, like skipped beats or pauses, which could indicate an arrhythmia or conduction issue exacerbated by the drug. And of course, check those key lab values we mentioned: potassium, magnesium, calcium, and creatinine for kidney function.
And for digoxin specifically, that pulse check takes on extra weight.
Huge weight. Because of its potent negative chronotropic effect, you must measure the apical pulse for 1 full minute before administering each dose. The standard rule is to withhold the dose and notify the prescriber if the pulse is less than 60 beats per minute, or sometimes greater than 100 or 120, depending on the clinical picture and specific orders.
Preventing dangerous bradycardia or heart block.
Exactly. And always double-check those potassium and magnesium levels are within normal limits before giving the dose to minimize toxicity risk.
Administration details matter too, like with food.
Yes. Oral digoxin can generally be given with meals to reduce GI upset, but not with high-fiber foods like bran cereals. Patients should separate digoxin doses from high-fiber meals by at least 2 hours because the fiber can bind the drug and decrease absorption.
Okay. And a massive safety point highlighted in the source: medication errors, specifically with dosage calculation.
Oh, this is critical, especially with digoxin because the doses are so small, often measured in micrograms or fractions of milligrams. Decimal point errors can be absolutely lethal.
What are the key rules from ISMP Canada mentioned?
The cardinal rules. Never use a trailing zero after a decimal point. For example, writing 1.0 milligram could easily be misread as 10 milligram, a tenfold overdose.
No trailing zeros.
And always use a leading zero before a decimal point for doses less than 1. Writing 0.25 milligrams could be misread as 25 milligrams, a hundredfold overdose. It must be written as 0.25 milligrams.
Always use a leading zero. Seems simple, but potentially life-saving.
Absolutely. That level of precision is non-negotiable with a drug like digoxin.
Okay, shifting to the patient's role. What are the key teaching points for someone living with heart failure on these medications?
First, they need to understand this is usually lifelong therapy. Adherence is crucial. Then, empower them with daily monitoring skills.
Like what?
Teach them how to take their own radial pulse rate accurately before taking their digoxin dose each day. And instruct them on daily weights same time each morning, after voiding before breakfast, wearing similar clothing and keeping a log.
Daily weights to catch fluid retention early.
Exactly. And they need crystal clear instructions on when to call their healthcare provider. What are the red flags?
Red flags would be
Report any pulse rate below 60 or maybe above 100 or 110 BPM, depending on their baseline and doctor's advice. Any symptoms suggesting toxicity, that anorexia, nausea, vomiting, dizziness, fainting spells, or those visual changes we talked about.
in the weight gain.
A sudden weight gain is a big warning sign of worsening fluid retention. The usual guideline is to report a gain of 1 kilogram, about 2.2 pounds or more, in 24 hours, or maybe 2 kilograms, about 5 pounds in a week.
Okay. What about missed doses?
Good question. The general rule for digoxin and many cardiac meds is if they remember within about 12 hours of the scheduled time, they can take the missed dose. If more than 12 hours have passed, they should skip that dose entirely and just take the next one at the regular time. Critically, never double up on doses to catch up.
Never double up. And the absolute final rule.
Never, ever abruptly stop taking any heart failure medication unless specifically told to by their prescriber. Sudden withdrawal can lead to a dangerous worsening of their condition.
Okay. So let's try to wrap this all up. What's the big picture here? We've covered a lot of ground, from basic physiology to complex drug interactions.
Well, I think the big picture is the complete evolution we've seen in heart failure treatment. We've moved way beyond just trying to make the heart pump harder with something like digoxin as the main strategy.
Right, it's shifted to this multi-drug, multi-target approach.
Exactly. The four-pillared approach for HFrEF,
Right.
the ACE inhibitor, or ARB, the beta blocker, the MRA, and now the SGLT2 inhibitor, is really focused on tackling these systemic issues, the neurohormonal overactivation, the fluid retention, and trying to actively prevent or reverse that negative LV remodeling. A much more holistic and effective strategy long-term.
So if we had to boil it down to, say, 3 key takeaways for our listeners from this deep dive.
Okay, 3 key takeaways. 1, master the tropics. You have to know inotropic force,
Yeah.
chronotropic rate, and dromotropic conduction to understand how these drugs work.
Tropics first. Got it. Takeaway 2.
2, the modern gold standard for HFrEF is that four-pillared approach we just discussed: ACE-ARB, beta blocker, MRA, and SGLT2 inhibitor. That's the foundation for improving survival and reducing hospitalizations.
4 pillars for HFrEF, and number 3.
Number 3, digoxin. Remember its history, but understand its current role is adjunctive. It's powerful for symptoms, especially with AFib, but it's dangerous due to that narrow therapeutic index. Vigilant monitoring is essential, and always watch for those classic signs of toxicity, especially the visual changes in GI upset.
Force rate conduction, 4 pillars, digoxin danger.
Yeah.
Excellent summary. Now for that final provocative thought.
Okay, here's something to chew on. We've talked a lot about the critical need for close monitoring, catching dysrhythmias with milrinone in the ICU, managing that razor-thin margin with digoxin, watching electrolytes, checking pulses. It requires intense human vigilance, right?
Absolutely.
So think about this. How might advancements in remote monitoring technology, things like wearable sensors, smart implants, continuous glucose monitors that also track other things, AI analysis of home data, how might that tech fundamentally change the safety landscape? Would it allow us to use some of these potent higher-risk drugs more effectively, or maybe even earlier, in patients outside the constant gaze of a critical care unit? Could technology enhance that necessary vigilance?
Extending that safety net beyond the hospital walls through tech. That's a really interesting question for the future of managing these complex patients. A fascinating thought to leave you all with. Thank you so much for making this deep dive with us today.